slash attendance sheet for us over time so we can track it? I'm not sure if you can speak right now, but that's something that we can talk about.
We've actually talked about it in some past meetings, so I know she knows how to do it.
Oh yeah, she knows how to do it for sure. Good. Okay, I think we'll get started so we leave enough time for everyone. I'll share my screen. So we have, let me just make sure, do we have the residents with us? Jeff's?
Yeah, we're all here. We're sitting in the team room.
Okay, can you guys turn on your video, please? Thanks. I want you to know how worried I am about the team getting infected with COVID. All of you who were with us this past spring know how intense it was. I have not done the numbers within neurosurgery, but system-wide, about 8% of our healthcare workers were infected with COVID. That represents a remarkable positive achievement considering what the infection rates were in supermarkets and so on up in the 20s and 30s. And it proves to me how important our behaviors were in preventing more of us from not getting sick. So masks, using PPE behavior, appropriate hand washing and so on, that really saved the department. And this is everyone, not just the residents. It's saved everyone. I don't want us to let our guard down, and you can see why. The virus is clearly spiking around the country. These are the numbers that you've all seen if you're looking at things. And the way that we got to this spike here, where this red spike is that before that red spike, there was a spike in the Western Pacific. And then it came and came to us. And so now we see a different spike coming back in the other states, which then could rebound and reverberate back to us. So I'm very, very concerned about that. Obviously, it's not just the infections, but there's a real death toll on this. And those of you who've been sick know that this can hit you incredibly hard. So I'm just asking everyone to take it seriously. This means not only in the hospital, but outside of the hospital too. Clearly, bars are the place where it may be the most contagious because of close proximity and so on. And speaking is clearly an issue. This is a really interesting video that shows the way that gases are exchanged when people are engaged in conversation. This goes on for 8 minutes, but what you can see is that each of these participants in the conversation is inhaling the gases of the other person. The way we speak sometimes has an impact on it. This is an article from Nature in February last year showing that particulate and aerosol emissions transmissions are directly correlated with the amplitude of the voice. So the way I'm speaking, which is loud right now so I can be heard through the microphone, is a way to maximally transmit particles and therefore viruses. Which means that conference rooms and conferences are a really good way to get transmitted. So I would encourage everyone to wear masks when you are in a room, and particularly in a conference room where people may be speaking loudly. During surgery, there are certain things that we do, and this is a case with Tony Del Signore that I asked him to record, because I noticed that when we put the endoscope in, not only were we generating aerosol droplets, but look at how they sit, look at how they linger. So now we're doing nothing. There's no suction inside. We actually remove the endoscope, do nothing, and you can see that they just sit there. And then you suck it up with the endoscope. Those are the large aerosol droplets that apparently are not as infectious, but hard for me to believe that those are not highly infectious. So what can we do? To me, the first and foremost is to wear a mask. And we can discuss this as to where you guys wear a mask. You can see I'm not wearing a mask right now, obviously. I'm in my office. I have 2 doors, and I try never to go outside of this office without my mask. Sometimes I do go out without a mask. And I'm gonna ask you right now, Ray, are you there? Is Ray part of this? Halima?
Yes.
Okay. All right.
Yes.
Halima, I want to do an exercise. I want you to tell me politely, Dr. Betterson, I see you're not wearing your mask. Can you please put it on? Or I think you should put it on. How's that?
I'm sorry, Dr. Patterson, we didn't have volume. So
Oh, I didn't have volume. Okay. I would like to do an exercise that is aimed at helping each other not get sick so that we can all show up to work and do what we want to do. So Halima, you see me. I'm not wearing a mask. I'm in the hall. I may poke my head into your office, and I do not have a mask. I want you to tell me, Dr. Betterson, I see you're not wearing a mask. Do you think you should be wearing one?
Dr. Patterson, I see that you're not wearing a mask. Do you think you should be wearing one?
Yes, you're right, Halima. I'm sorry. I'm going to go get it right now. Thank you. So we need to help each other. What we realized in the early phases of the pandemic in KCC Neuro ICU was that it was observers, particularly neurosurgeon observers, that would make the observation that someone was exiting a COVID positive room or transmitting, going through the ICU without proper PPE behavior. We need to reinforce this among each other. I really do not want people getting sick. It's very important to me personally, but to each of you. And we don't want you getting the other ones sick as well. So now, what to do when you're in your conference room? My preference would be that you wear a mask whenever possible in your conference room, all of you. On the other hand, and we can discuss this, I'd like to discuss it going forward, there's a certain sense in which the residents are the work equivalent of a family group. And when you're at home with your family, you don't wear a mask, but you all agree as a family that when you're outside of the room, outside of the home, your behaviors are such that you're going to protect your family members. So I'd like you to think about this. I've spoken about it with Jay. My preference would be that you're wearing a mask at all times, but I understand that when you're in the confines of your own home, that may no longer be valid, but then that requires extra vigilance when you're outside of the room. I suggest that for all conferences, vascular conference, spine conference, any conference where you're in a room together, everyone is wearing a mask. It is a requirement of Mount Sinai Hospital to wear a mask when you're in the public area. That's not a suggestion, it's a rule. And so you should have no problem when you see anyone in the hallway to ask them to please put on a mask, particularly, those of us we interact with. So I think I've made my point. Are there any comments, Ernest?
No, I think you've made the point perfectly clear, Dr. Betterson. I think what's also important is that people look up to us as neurosurgery residents as exemplars of medicine and public health. So yeah, I think we set an example even when we don't realize that we are. So it's that much more important for us to just also make sure we're modeling how to protect others from the virus besides protecting ourselves.
Yeah. Dr. Mako, I don't know if you are available to comment, but obviously we're looking for your guidance as well when the time comes. Okay, any other comments? Okay. If not, I wanted to turn to a couple of other items. Every year I go through our department accomplishments, by which I mean our faculty accomplishments, and I am also happy to include resident accomplishments. This gets sent to the Board of Trustees. It is also presented at convocation and in publications and so on. There's a form, which is here, that every faculty should go to. Gillian can help. If you want to submit to us, we can help you get this on the form. But it is important for us to have all the work that is done recognized. Here's the deadline. We've got about 3 or 4 weeks to do it. And we will send you an email with this and probably remind you a couple of times. What we're interested in is your national and international awards, your professional society entrances and so on from other academic institutions, keynote speaking engagement, and chair roles on external committees. Even if you were on that committee last year, if you're on it this year, please let us know if you're the chair of that committee. And almost every faculty member is doing this, so the list is very impressive actually, and I would really like you to be recognized. And I'd like the department to be recognized. You're not supposed to submit your grants, past president awards, adjunct, the best doctors of any type, committee memberships, local and Sinai awards. So those are the things that that I'd like you to submit. Finally, before we get started, I wanted to welcome 4 new members of the department's family. The first is Sarah Nelson, who is the new Associate Director of the Neuroscience Surgery Neurology ICU at Mount Sinai West. She's Assistant Professor in our departments. She did her undergrad at MIT in biology, Stanford, public health at Johns Hopkins, neurology residency, and a neurocritical care fellowship. Not too shabby, Sarah. We're really happy to have you, and look forward to have you be a very active and vocal member of the department and the outstanding division of neurocritical care medicine that we have. So welcome. And there'll be more to come on this. Spiridula Tsetsu, those of you who have been around have known her, also has one of the most amazing training records that I have ever seen of anyone in EEG and epilepsy, clinical research, neurogenetics, neurocritical care, and an IOM fellowships at MGH. This last one went from you frequently. Although all of you who worked every day know, we're welcoming 2 new PGY1s. Halima Tabani got her degree at Aga Khan University Hospital. She has extensive research experience. I first became introduced to Halima through Michael Lawton, who first started writing me, then would not let up and called me until he got me on the phone. And this was over a period of weeks in which he really needed to tell me about Halima. And by that time, he knew that we had a pre-residency fellowship. We were developing a pathway like this that Halima has successfully navigated. And the results are nothing short of spectacular. So we're really happy to have you, Halima. You can see she's a very accomplished human being and is already deeply embedded member of the family. Matt Carr, I haven't seen you walking around yet, or maybe I have, but I don't remember it or haven't recognized you under the mask. But please say hi when our paths cross. Undergrad at UMaryland College Park, majoring in physiology and neurobiology, several key awards and scholarship, evidence of excellence in academia. So we're really looking forward to get to know you a little bit and to have you as a member. So that's right, a little over time, but I think I'll stop there and we can move on if we have time, Chris, to where we are on our presentation. Thanks.
Thank you.
Sorry, that took me a second to unmute myself. So I just have 2 SANS questions before we get to spine conference this morning. I'll start with our brand new PGY2s. So Alex, why don't you start with this question? Which of the following diagnoses best describes this pictured congenital anomaly?
See, maybe A, sinus pericranial.
So go through what are each of those answers, and then tell me why it's not sinus pericranii.
I believe sinus pericrania is when kind of the sinus perforates through the pericranium. This would not be because it more involves the cutaneous layers.
So it's a sinus pericranii. It's close. It's can anyone else, let's see, Jeff Zimmering, can you tell us what sinus pericranii represents? Or Ray, if Jeff is
yeah,
unavailable.
Jeff is not on. Sinus pericranii, I remember it's intradural sinus that communicates with a scalp venous, with a scalp vein, and it should be covered over by skin. So
right. So it's an abnormal venous connection between the extracranial and intracranial space. Typically, a connection with a sinus or a large vein. What about parietal foramina? Since you got that one right, what is this?
So parietal foramina is abnormal skull opening in a parietal area.
Which is usually bilateral, symmetric. It will probably show up in a future SANS question to try to trick one of you. What about cutis aplasia? Let's go back to Alex.
In this case is when the scalp layers don't properly form during development.
Right, so it's congenital absence of one or more of the scalp layers, can also include the skull. And then lastly, encephalocele, Alex.
Is when a portion of the cerebrum is herniated out from the cranial vault.
Almost correct. Any portion of the brain can include cerebellum, brainstem, not necessarily just the supratentorial space. And so now that you've defined all of these, what is this picture representing?
Cutis aplasia.
Yes. So this is a really severe form of cutis aplasia where all of the layers of the scalp and the skull are missing, and this is just the dura exposed at birth. And so this required a fairly significant scalp mobilization and skin grafts and multiple repairs to ultimately cover this, and a cranioplasty as well. Here's just an example of parietal foramina in a 3D reconstruction of the scan. You'll often be asked on the boards, they'll basically show a skull X-ray or a CT like this and ask you what this is. And they'll give you the option of saying this patient has had neurosurgery before as one of the questions, but this is a classic congenital malformation. Okay, and let's go to Abi for this one. So this patient, the patient with these pictured anomalies also has bicoronal craniosynostosis. Which of the following syndromes is he most likely to have?
I think it's B, because it's combined with extra deformities of the distal extremities. I think all of them cause craniosynostosis. I think B also causes lower extremity deformities.
So let's do the same thing we did on the last one, but we'll move pretty quickly. So all of these, you're correct that all of these come with craniosynostosis, typically multi-suture, and the classic anomaly is bicoronal synostosis. With Cruzons, what are the characteristic abnormalities? Or better yet, I'll lead you a little bit and then I'll show you on the next slide. So do patients with Cruzons typically have syndactyly?
No.
No. And do they typically have normal or abnormal intelligence?
Normal.
Normal, correct. Let's go to Aperts. Skip over Pfeiffer's and show you on the next slide.
Yeah. So that would be like abnormal intelligence, along with craniosynostosis, and you have syndactyly.
And syndactyl. And the syndactyly in Aperts is typically symmetric. So at least both hands and often both hands and feet are involved.
Okay.
So this is an example of Apert syndrome, classic appearance of the syndactyly, often including all fingers. It's symmetric. These patients have cognitive delays as well. And this is a summary of the Aperts, Cruzons, and Pfeiffers are the more commons. I threw Sathrochotzen in there as an additional answer, but it's extraordinarily rare. All of them are characterized by multi-suture synostosis. As I mentioned, Aperts has symmetric syndactyly as well as developmental delay, whereas Cruzon has mostly the facial abnormalities and has an association with Chiari, but typically normal cognitive development. And then Pfeiffer's involves also mid-face hypoplasia, and broad fingers can include syndactyly, but it's not the universal symmetric syndactyly that you get with Aperts. All right, so I have to figure out how to unshare my screen. Okay, there we go. So we'll go to Jeff for spine conference next.
All right. Can you see my screen okay?
Yes.
All right, good morning, everyone. So I'm Jeff Gilligan, newly PGY6. This past year, I've spent with Dr. Cleary doing an Unfolded Fellowship for Complex Spine. It's been a great year. This will be my last grand rounds for spine conference this year. It's been fun going over different topics. And today I'll be going over something that we encounter a lot with spine surgery. It's revision surgery that we don't often talk about a lot. So I'll be going through this kind of a brief overview, but then I'll be going through actual cases that I've done this year. And the other great thing about spending this year with Dr. Cleary is that we get to spend some time in the clinic with him, where he gives some autonomy of kind of deciding what to do for certain cases, and then being able to see these patients post-operatively and follow up and actually see how they're doing, and kind of actually see with my own eyes of whether or not the different choices we made help these patients. So we'll be kind of going through that as this talk. So revision spine surgery happens, in the literature from 5 to about 14%. It gets more and more prevalent as the bigger surgeries you do for a deformity, whether it's scoliosis or sagittal imbalance, which is up to about 17%. And when patients who undergo these repeated surgeries, they also get labeled with kind of condition referred to as that we hear as a failed back surgery syndrome. So failed back syndrome basically falls into 4 categories, where the patients basically were poorly selected. There was an incorrect diagnosis given that led to potentially an incorrect procedure, or just a failure to achieve the intended surgical goal. Improperly chosen and treated patients, the most common pathologies that still lead to revision surgery and failed back syndrome include recurrent disc herniation, pseudoarthrosis, as well as adjacent segment disease. So poor patient selection. What this can kind of refer to is patients who have psychosocial issues, whether depression, can be workers' comp, where their history might be unreliable as they're trying to have their own kind of agenda pushing for potential surgery. Other things include obesity, high comorbidities, smoking, as well as low income or little family or friend support. Incorrect diagnosis. This can be where you're just incorrectly diagnosing what pathology is actually going on. This can include vascular conditions. So let's see who's on right now. Actually, Matt Carr, are you on right now? How would you be able to distinguish between something like vascular claudication versus neurogenic claudication?
I believe vascular claudication would be worse with use and overuse as opposed to neurogenic claudication, which I think could be a little more positional.
Perfect. Yeah. The classic for determining that is usually the patients get relief for walking for the neurogenic if they're kind of stooped over. A lot of patients say that you're using like a shopping cart or something like that. Whereas just like you said, if it's vascular, it's usually just exercise dependent, not positional. But also can be GYN conditions, orthopedic, SI joint disease. How about Abhi? Abhi, how would you on an exam distinguish back pain or radiculopathy from SI joint disease? Or anyone else on the?
You have focal. You can have point tenderness for psychotic joint disease, as opposed to like.
Okay. But basically, you can kind of elicit it by just pressing down on the joint itself, or you can do a maneuver, I believe it's called Farber's maneuver, where you have one leg straight, the other one flexed and crossed, and you push down on that hip there. It should be able to elicit the pain. And then you have neoplasm as well as peripheral nerve lesions. Next is just diagnosis. I think that's kind of the most crucial point of kind of deciding whether a patient is going to benefit from revision spine surgery. And this would be eliciting a very good history, determining what symptoms they have, whether or not they have specific dermatome distributions, as well as the timing of the pain. And if they had previous surgeries, were there any pain-free intervals, as well as the physical exam and imaging. So for causes in patients with no pain-free intervals can include just doing the wrong level. It can be retained discs, issues with the hardware, where potentially the screws causing compression of the nerve. You can have complex regional pain syndrome or infection. And then subacute, you can have more things like pseudomeningocele, arachnoiditis, again, infection, or again, recurrent disc herniation. And the more long-term can be adjacent segment disease, pseudo disc herniation as well as instability or hardware breakdown. And I'll send these slides out. I don't want to belabor too much on these charts, but you can kind of create like an algorithm in your head of kind of the timing and the symptoms to try to narrow down your kind of differential what's going on. And as I kind of alluded to, your treatment should be individualized for each patient based on their history and their symptoms, as well as taking into account psychosocial issues as well. And obviously, before getting to surgical treatments, you should try to use all non-surgical management, NSAIDs, PT, as well as injections. And again, here's some photos for some algorithms, but I really want to get down to some cases. So just before we start, I just want to make sure all the residents are available to answer these questions, because I'll be calling on you guys as we go through. All right, so first case is a 38-year-old female. She previously had a right-sided MIS L5S1 microdisc 6 weeks prior, and there are no intra-op complications. She initially did well for the first 2 weeks, but then began to have significant headache, nausea, and vomiting. Initial MRI was negative for any large collection, but she did note some improvement with bed rest, but then her symptoms return. So for my first question, what do you suspect is going on? bulima.
CSF.
Good. So what would be your next step to diagnosis?
So we already have an MRI, which is negative for any collection. We could potentially get a CT myelogram to look for an occult CSF bleed.
Perfect. Exactly. So that's what we did. And we found this collection that has some contrast in it. So exactly, as you said, we found the CSF leak. So what would you do for this patient? She's symptomatic and has a pseudomeningocele.
So we take her for a re-op for CSF leak repair. Probably not do it MIS, so that do an open re-exploration and CSF leak repair. Good.
Yeah, so we returned for an open L5S1 exploration. We opened up some more bone space and we did a primary repair of the CSF leak. We actually found the durotomy on our remaining lamina with a sharp bone edge, and we repaired it, like I said, primarily with a fat graft and Duracell Exact. So CSF leaks, pseudomeningoceles, can be due to actual CSF leak intraoperative or unrecognized or postoperative, like in this case. The big takeaway which you got is that it can be the symptomatics from positional headaches or even radicular pain. Sometimes MRI show it, but CT myelogram is the best to kind of show extrapolation of contrast. And treatment initially should be with bed rest. You could potentially consider lumbar drain for very small leaks or even a blood patch. Or the kind of definitive treatment would be revision surgery. Next case is a 78-year-old gentleman. Previously had a MIS 4-5 microdisc for severe right lower leg radiculopathy, no complications. He did well, but symptoms returned 3 months later. Trevor, what would be your next step seeing this patient in the office?
So after seeing the patient in the office, I would, given that he's had previous surgery and is having a return of the symptoms, I'd get an MR lumbar spine.
Good. So here's his initial MRI showing a large L4-5 disc herniation. And then here's his 3-month post-op MRI with a new large disc herniation. And Trevor, just keep it going. What would be your next operative plan? Like I said, he has still a return of his right lower extremity radiculopathy, but also a component of back pain as well now.
Given he's got back pain as well, I mean, more likely from the extrusion of the disc centrally. I think we could try and do another MIS, just like a matrix decompression at the same level, and see if we can clear out most of the disc again.
Good, that's reasonable. This gentleman was actually a radiologist in our system, and he wanted a definitive treatment. So given his back pain as well as some fluid in the joints, we opted to go with a fusion. So we did an L4-5 TLIF to definitively get out all the disc. And he did quite well from it. So just recurrent disc herniation can happen 5 to 10% of the time, often pain-free intervals with the return of the pre-op symptoms. You need to evaluate post-operatively for any instability. That could have been pars defect, fluid in the joints, dynamic instability. And the treatment, like you said, can be potentially just a revision microdisc, or if there's some instability, a fusion. Next patient is a 27-year-old female, again, a L5S1 microdisc 1 year prior that had complete resolution of her radicular pain. She came back after being assaulted with a hard fall about 9 months ago and had progressive lower extremity radiculopathy in both legs, as well as numbness. And so the pain traveled down bilateral back aspect of both legs, no improvement with PT. And then she did note temporary improvement with steroid injections. Here's her initial MRI with that disc herniation. And then here's her new updated MRI after her assault. X-rays are on the right, showing no dynamic instability. Alex, just kind of given that history, would you decide to operate on this patient? Why or why not?
So it looks like she does have a disc at 5'1". However, no dynamic instability, as you mentioned. I think the steroids, the fact that she improved with steroids is a good pretest as far as the fact that she could potentially benefit from a decompression. I think the fact that she otherwise failed conservative therapy, I mean, I don't think it's unreasonable to try one more steroid injection to see if she has more benefit, but I think she could potentially benefit from a decompression as the steroid did temporarily alleviate her symptoms.
Good, perfect, yeah. When you look at this MRI, it's nothing that noteworthy. She does have some bilateral lateral recess stenosis, but exactly kind of what exactly you said, where she had this clear dermatome radiculopathy, and the fact that she gotten better with these localized steroid injections guided us to do surgery. So she went to the OR for bilateral laminotomies as well as discectomy, and 6 weeks follow-up, her radiculopathy significantly improved. Next patient is a 62-year-old female, previous back injury 30 years ago, now presents with progressive low back pain, as well as left greater than right radiculopathy down the side of her legs to the top of her foot. She was neuro intact. Here's her most recent MRI. Let's see who else. Ray, what would you be your next step in management for this patient?
So on the MRI, there's definitely lateral recess and foraminal stenosis on both sides. But before I do anything, sorry, Jeff, did you say they already got dynamic imaging?
No, I didn't, but that's
a
good thing.
Yeah.
So exactly, we got dynamic imaging, and what you can see that there's, she basically has a slip at 4.5. So what would this change for your management of how to treat this patient?
So that movement implies instability at that level and likely cause of her back pain. So I would more likely to consider a fusion rather than simple decompression.
Perfect. So we did an L4-5 TLIF with bilateral medial stectomies as well as laminotomies. Patient initially did well, improved with her back pain, radiculopathy, but about 3 to 4 weeks later developed lower extremity radiculopathy again, no new neuro deficits. Ray, what would be your next step and your potential concern?
Initially, was bilateral. It's too early to comment on arthrosis.
How about just starting with what would be your next step if this patient came to the ED and you're going to see this patient?
Exam and imaging.
Sure. What kind of imaging would you like?
I would get another MRI.
Perfect. So here's her MRI. Like I said, in this case, we did do a full laminectomy. So she still has some compression there as well as some disc fragment causing her symptoms. So what we did was we returned to the OR for a full laminectomy. This was a good learning point for me, even though on her initial MRI she didn't have that much stenosis. Since then, for any kind of TLIF or kind of fusion, we've done full laminectomies to kind of prevent this from happening again. I had her 6-week follow-up. She was significantly better, just with some mild back pain. Next patient, a 46-year-old male, 4 to S1 decompression fusion in 2014. He presents with 6 months of low back pain, lower extremity radiculopathy in front of his legs. That's worse with ambulation or activity. And here's his MRI. George, how about you describe what we're seeing on the MRI here?
So we can see a T2 lumbar. Sagittal lumbar T2. I'm not sure exactly what the level is, but there is essentially a herniated disc. But sorry, that must be L23, and it's compressing on the codiclina.
All right, so basically this is actually level 3-4. Okay, we're seeing a disc herniation, as well as pretty significant fluid in the joints. And again, the previous fusion was from 4 to S1. So Trevor, what would you say this is an example of?
It's adjacent segment disease.
Good. So I say next step here, but I'm just going to kind of speed up here a little bit. We did dynamic imaging, which shows that there is a slip here, dynamic instability. Trevor, what would be your operative plan?
So I would extend up a level above the instability. So I would go up to extension to 3, and then as you put up there on the screen, yeah, do a T-lift as well at 3-4.
Great. At 6-week follow-up for this gentleman, lower extremity was resolved. Had his lower back pain significantly improved, still some intermittent numbness. So adjacent segment disease results from structural instability or accelerated degeneration at the levels above or below a fusion segment. Incidence can be as high as 20 to 40%. And it's usually secondary to mechanical stress at the level adjacent to the fusion. I have here a few tables, what you see at the different levels above or below of the pathology of the adjacent segment, where it can be slips, instability, herniated discs, stenosis, and so forth. And here are some of the risk factors that can lead to adjacent segment disease. Okay, so this next patient is a 63-year-old female, previous L4-5 laminectomy at an outside hospital in 2008 for low back pain. And she did not improve at all. And since then had progressed with low back pain, and now is having severe lower extremity radiculopathy down the sides of both legs. And here's her presentation MRI. Neck card. What are you seeing in this this MRI here? All right, how about Halima?
So there's a significant slip at L4-5. Would get dynamic imaging.
Okay. She still has a standing X-ray. I don't have the dynamic, but she already has, it's dynamically unstable. So what would be your operative plan?
So do a decompression and fusion L4-5.
Good. So we did L4-5 T-lift. She was discharged on day 3 with complete resolution of her lower extremity pain. At 6-week follow-up, she didn't even have any back pain as well and was extremely happy, and she was ambulating well. So this would be, it would be an example of iatrogenic spondylolisthesis. Likely this patient who first presented with low back pain likely had a grade 1 spondylolisthesis at that time, and instead got a laminectomy, which obviously did not improve her symptoms and led to increased stability, leading to probably a grade 2 spondy. All right, next is a 72-year-old female, previous 3-4 laminectomy 2 years ago at an outside hospital for lower extremity symptoms. She initially resolved, but now has progressive low back pain as well as radiculopathy over the past 6 months. Here's her MRI, as well as some X-rays. Ray, do you see anything notable on either?
Yeah, on the X-ray, she has pretty significant levoscoliosis of the lumbar area. MRI, just on the sagittal, there's not that much central stenosis.
Good, but I like how you kind of noted that it's just kind of centrally doesn't look too bad, and if you go out more laterally, you can see that there's big disc herniations and stenosis bilaterally in these foramen, kind of explaining her radicular symptoms. So we actually did a 3-level T-lift for her to help correct her scoliosis. We did all the T-lift cages on one side to help correct that scoliosis. We discharged her on day 4. 6-week follow-up, her radiculopathy was resolved, still recovering with some low back pain. Okay, next is the gentleman. He was hiking in Albania. Maybe if you guys remember the story. He had a T12 burst fracture at that time. He went T10 to L2 fusion there with a T12 laminectomy. He came back to us and came to the ED with continued left lower extremity weakness and was unable to walk with bowel and urinary incontinence. And here's his MRI. And here's his CT. Alex, what would you want to do for this gentleman? Still complaining of not being able to walk, pain. What would you say the issue is with him?
It's hard to tell the level. It's 11. It looks like there's less fragment. Looks like they're responsible for his incontinence as well as his lower extremity. Oh,
yeah, exactly.
Sorry, I was mute.
Could you just repeat that? I heard you, but just
no, absolutely. It's hard to actually tell what level. I think maybe T11 or T12, but it looks like there's a retropulse fragment within the canal that's most likely responsible for his incontinence, as well as his lower extremity weakness around the level of the caudoclina or the conus.
what would you want to do operatively to help this gentleman?
So at that level, he would need a wide decompression laminectomy. Obviously, we have to, if we're able to push in that retropulse fragment, then to do that, but we may have to actually extract it to take pressure off the cord at that level.
Good. So we took him for revision fusion, a very wide laminectomy, like you said, and then we actually did a bilateral transpedicular decompression to get to that ventral retropulse piece. And here's our postoperative where we gave that cord as much space as possible as we were able to get that ventral retropulse fragment as well. His discharge to acute rehab was full strength, but still needing to walk with a walker, which is better than what he came in with. We saw him at 6 weeks postoperatively, improved ambulation, but still using a walker. Next is a 58-year-old female, previously had an L2 to pelvis fusion 18 months prior, and she presented with several months of worsening back pain, as well as ambulation and posture. Here's your standing scoliosis X-ray. Alejandro, you're on, right? Kind of seeing this X-ray, what are important measurements and angles that you'd want to measure for this to kind of see if this patient needs to be treated and how to treat them? All right, Ray.
So definitely need to measure lumbar lordosis, degree of lumbar lordosis, and also overall alignment. I'm blanking on the name of that measurement.
Okay, what would you kind of just grossly say her pathology is? What's wrong with this X-ray?
There's not enough lumbar lordosis.
Okay, so basically, I would say sagittal imbalance would be basically the pathology. She's too much leaning forward, and as you say, it's resulting from a hypolumbar lordosis. Mm-hmm. Okay, so the measurements I just want you guys to get into a habit of doing for these. You want to get your sagittal vertical axis, which is measured from a plumb line from C7. And that goes straight down. And then you measure the distance from the back of the end plate of S1. For her, it was very high. It was 10.5 centimeters. Next is the different pelvic measurements, PI. I'm not going to belabor to go through them now, but also measuring lumbar lordosis. And then importantly, lordosis from L4 to S1, where you should have 2/3 of your lumbar lordosis through those segments. I've previously kind of discussed the GAP score, kind of measuring sagittal imbalance, but for hers, it's very severe. So for her, we did an exploration T10 to pelvis, where we did pontiostiotomies at L4, 5S1. We were able to correct her quite well for her. Now her SVA is just 3. Her PI is always going to stay the same, but her lumbar lordosis is significantly better. She was discharged to rehab post-op day 6. Her follow-up is delayed to COVID, but at least on phone calls, she had improved ambulation. I previously talked about this. I don't have much time, so I'm going to go through this. All right. This is a 39-year-old gentleman, previous car accident with a T5-6 fracture dislocation, a fusion at that time with laminectomy. He initially did well, but had gradual improvement of strength, but has progressive weakness and numbness in his legs for the past 3 months. Here's his MRI. Might be a little bit hard to see, but Abhi, what would you wager is going on with this gentleman? I think the best image is that far right axial cut. And again, he had a traumatic injury and then now is having progressive kind of myelopathy picture.
So by looking at the MRI, it looks like he's having I think from his traumatic injury, he's having basically the loss of vertebral body height, which is causing like kyphosis and instability in the region.
Okay.
And,
Trevor, how about you help him out?
All right, sorry. Okay, yeah, so you can see some hyper intensity in the T2 and the center of the cord. Likely obviously syrinx from his trauma. That could be causing his weakness and his symptoms.
I just wanted to point out here, which isn't in the cord, it's basically a separate CSF space. So it's indicative that there might be some arachnoiditis going on, causing compression, which probably led to the syrinx. Okay, so we took this gentleman for an exploration, laminectomy, and then we did an intradural detethering. We found extensive intradural adhesions. We released them and saw improvement of CSF flow. He was discharged home on postoperative 3 with much better ambulation and numbness. And again, this is an adhesive arachnoiditis. It can be an intradural scar formation that can form often after trauma or blood in the for surgery or tumor, and treatment is lysis of these adhesions or scar to reestablish the flow. All right, I just have time for a few more. Let me just, this is a good one. Okay, this is a 6-year-old female, previous L4-5 decompression fusion, 2 years prior for low back pain. She had no improvement after her surgery, and her back pain continued to get worse. I think Alejandro, you said you're back on. I guess first off, can you tell me what kind of screws these are? Are these normal pedicle screws that we normally see, or are they something different?
Sure. I mean, the only thing that stands out to me is the kind of like polyaxial head. That I mean, they're still. That's what we typically use. I don't see anything special about them.
Right. So I just want to point out, at least on the AP here, it looks like they're going from medial to lateral, whereas normally our pedicle screws are going lateral to medial. So these are called cortical screws. Basically, they go in a different trajectory that go from medial to lateral and staying in the cortical part of the pedicle. The potential benefit for these is that it requires less dissection. As you can see, normally we have to go out to the transverse processes for our pedicle screws, whereas it can stay more midline. The issue with this is because you're not doing that, it has less fusion rates, basically. So I don't want to belabor this, but basically this lady did not fuse. There's no fusion mass between these. This is an example of pseudoarthrosis. So we did hers, a revision instrumentation fusion. As you can see, this is the different in the screws where these are going lateral to medial. Okay. She was discharged to rehab on postoperative 5 with some mild back pain. I just have 2 more minutes. So I'll kind of go through here. I guess I'll show this one too. It will be my last one. This is a 50-year-old female. Previously had a T4 to pelvis fusion for AIS 2 years ago. initially did well, but had progressive low back pain for the last 3 months. And Alex, what do you see going on with these X-rays?
Looks like there's a disjunction of the right rod. Looks like it's snapped.
Correct. Yep. Both rods snapped.
Or actually both sides left as well.
So we did exploration, revision, and fusion at that time to create this construct. She initially did well, but then 5 months post-op from this surgery, she raised from a seated position, felt a pop again, and experienced severe lower extremity radiculopathy, low back pain, and progressive difficulty. Unfortunately, she basically broke down again. We can see rods actually that came out of their connectors, and even here too. So we just recently took her for another exploration, revision, and fusion. We did bilateral kickstand rods to iliac bolts, and we basically connected her with even more rods in between. So here's the final construct. Hopefully she hangs in there now because it's been pretty painful. She's discharged on day 3. She's ambulatory at her 3-week telephone follow-up visit. She's doing well, decreasing pain medication, ambulating well. These last 2 are actually ones that we've seen recently. So I'll just show these quickly. This is a 34-year-old woman who basically had a Chiari symptoms, and instead of just getting a Chiari decompression, she had an occiput to C2 fusion. Obviously, she did not do well from this, and she actually developed significant swallowing dysfunction and sleep apnea following the surgery. And this is her fusion after her Chiari. And you can see here some haloing around these screws, so it means that she didn't fuse. And even though we weren't able to see it clearly in any of the imaging that I can show, she likely had some type of glossopharyngeal nerve disruption from one of these screws. So we took her for removal of hardware. 2-week follow-up, she's improved swallowing and mobility of head. And this last one is actually someone who's on our service now. This is an 18-year-old female who presented to an outside hospital in 2016 with neck shoulder pain, progressive hand numbness, had this MRI. I'll just go through quickly. She basically has a mild Chiari, about 5 millimeters of displacement here. And instead of getting a decompression as you would assume, she got a 4-level ACDF in a 16-year-old.
What?
She obviously did not do well. She presented to Dr. Creedy's office, continued symptoms, as well as new complex regional pain syndrome. And this Monday, she actually went for what we think is her correct surgery, it's decompression, C1 laminae, as well as expansile duroplasty. So thank you. And again, I just want to have a special thank you to Dr. Creedy for this year. It's been extremely educational and very enjoyable. Thank you, guys.
Awesome presentation. And now we'll move on to our guest speaker. It is a great pleasure to introduce Dr. Kevin Cleary and his team, Dr. Karan Sharma, Dr. Ray Chen, and Dr. Dimitri Segunis. Dr. Cleary is the Associate Director of Engineering at the Sheikh Zayed Institute for Pediatric Device Innovation at Children's National Hospital. He leads a team of engineers and scientists working with their clinical colleagues to develop biomedical devices for pediatric care. And he's internationally recognized for his research in medical robotics. He's also NIH funded to develop a body-mounted robot for pediatric arthrography and is now applying his expertise to a problem we're much more familiar with, intracerebral hemorrhage evacuation. So, Dr. Cleary, thank you very much for speaking with us today. And I'll try to see if I can allow you to share your screen. There you go. I think you might be on mute. Okay, I'm unmuting you. There we go. You're unmuted now.
Okay, great. I hope you all can hear me okay. And let me try to play the slideshow here too as well. Okay, and Chris, how is the sound then?
Very good.
Good. Okay, great. All right. Well, it's a great pleasure to be here this morning. It's always a little strange doing things by Zoom because it's really hard to see the audience reaction. So anyway, I will try to move things along. I'm very sorry that I couldn't be there in person. I had a nice trip set up in April, but of course something called COVID happened, which we're all still dealing with right here. So anyway, I think this is fantastic that we can do it by Zoom. And, you know, when Chris said maybe we'll have a 50 or more people, and I saw the list, I'm like, wow, that's pretty impressive. So, you know, maybe in this way we can reach more people too. So there may be some advantages. So today I'm going to talk about MRI robotics for minimally invasive procedures. And the main idea is to be able to do things in the bore of the magnet. So you can actually have imaging throughout the procedure. And since a magnet is a fairly closed bore system and difficult to reach inside, the robotic devices can help with that. As usual for these clinical talks, I have a lot of slides, so I'll go quickly through some of the background. And then towards the end, we'll talk about an ICH project that we hope to be starting soon. So we'll talk a little bit about our research institute, a little bit about the history of MRI robotics, and then 3 body-mounted systems that we've been developing here for work in the MRI: Arthrobot for shoulder arthrography, PainBot for back pain, BoneBot for long bone biopsy, and then of course the one of most interest probably to this audience will be the MRI robotics for ICH evacuation. So children's here, I'm actually up here on the top floor of the hospital. Not sure my cursor shows up very well, but we have a very nice view over the city, and we won't get into politics, but I can say nothing's happening down there from my viewpoint right here. We are a fairly large hospital, about 300 beds. We're the major children's hospital for the Washington, D.C. area. And we have the various units, all the intensive care units here, and a lot of regional outpatient specialties. And like most type academic medical centers, we have a 3-part mission with research, clinical care, and education. I was actually at Georgetown doing work in radiology research 10 years ago and 11 years ago now, and I saw this headline: Abu Dhabi gives US hospital 150 million. I said, wow, that's a lot of money. And I had been at Georgetown almost 15 years, and I said, well, maybe it's time to do something new. And I was able to come across town to Children's when we set up this new research institute for pediatric biomedical devices. And the idea of the institute here was a story of a child who had a very complex disease and how they would be treated, and bringing all the parts of medicine together to handle that. So pain medicine to alleviate pain, immunology to fight disease, bioengineering, of course. You know, we believe that technology is becoming more and more prevalent in medicine. So the idea of bringing engineers and clinicians together to develop the next generation of treatments. And finalize personalized medicine, not only just in genetics as well, but even the use of imaging and things like that to personalize the care. We have this nice research space at the top of the hospital. The green is mostly wet labs, the blue is mostly offices. But the beauty here is we have both engineers and clinicians sitting side by side. So some of the physicians have their offices here. You know, we can see the doctors in the cafeteria. We can go down to the ORs. We're all physically in the same building. So it's very convenient for collaborations. In bioengineering, the main idea basically is to make surgery more precise and less invasive. So that's our mantra. As we move to more and more minimally invasive procedures, it's great for the patient, but I do think it takes more skill on the part of the physician, because you can't just cut them wide open and have access to everything you want to see. So we need to develop technology that can help physicians do minimally invasive procedures through smaller and smaller openings. For bioengineering, we want to be a leader in technology development, clinical translation, and we also look at product commercialization. Pediatrics market is typically underserved and it's hard to make a business case, but we feel if we don't try to commercialize some things, we won't have the same impact. At the same time, as I mentioned, we want to enable the next generation of minimally invasive procedures, and that's really technology developments. In some sense, I feel like we have a lot of technology. Certainly everyone has their smartphone that they can, you know, and the GPS and things like that, that they can manipulate around, and that works around the world. But how do we integrate the technology in medicine is really the issue. And we are a resource for the hospital to provide technology solutions to clinical problems. Okay, so let's switch gears here a little bit and talk about MRI compatible robotics. So again, we'll talk about some of the background, and then we'll talk about these 4 systems under development. But the key idea is that it basically does take specialized engineering techniques to work in the MRI environment. MRI is kind of a mystique in some ways too, you know, with the high field, you know, of course, you know, don't bring your credit cards into the MRI, you know, you won't be able to use them afterwards. And you may have all seen the pictures of like the vacuum cleaner stuck in the MRI when the janitor brought it in one night and didn't realize that the magnet quote is always on, at least the magnetic field is always present. But once you get used to it, just like any environment, you know, it is an environment that can be tamed. And I think the challenges now can be met by technology development, and we can build systems that can actually work in the MRI environment. So the rationale for MRI guided interventions, you know, as you know, is that MRI really provides exquisite soft tissue discrimination, particularly for MSK type procedures. Obviously, it eliminates the radiation associated with CT or fluoroscopy interventions, but MRI can also provide other functionalities such as monitoring of thermal treatments. We won't talk about it today, but my colleague, Dr. Sharma, does a number of HIFU procedures, high intensity focused ultrasound in kids, where you actually can use an ultrasound transducer to somewhat cook the tissue in a minimally invasive way, but you use the MRI for thermal monitoring. So MRI is really a very functional system that can be used in a lot of different ways. MRI compatible robotics, however, most MRI are closed bore with 60 centimeter or 70 centimeter bore. And here we have Dr. Sharma trying to reach in the magnet just in a phantom study so that he can actually look at the screen and he can kind of watch in real time as he manipulates a needle or other instrument. So it's kind of cool. I mean, nobody's ever shown there's a problem of being an MRI and having all your proteins aligned. You know, that protons, that's what MRI does, you know, as well. But, you know, we obviously know that radiation dose is an issue and you have to wear shielding. On the other hand, it's not very convenient to work like this. I always joke with Dr. Sharma that the problem here is his arm is not long enough. If you were tall like me and had a longer arm, this would work fine. But obviously, this is not ergonomic. But so the robot can provide a steady guide for instrumentation. The robot can enable in-bore interventions, and it can also enable real-time image guidance during intervention. So the idea is that you would actually be watching as the procedure unfolds, and you would be monitoring the whole time as well. However, the difficulty of working in the MR environment basically is due to this very strong magnetic fields. So we won't get into all the MRI physics today. And I was told not to put any equations in today, right? Right, Chris? I wanted to make sure, no equations, okay? Just pictures, we always joke right here too. But it really is kind of an art form again, and you need MRI physicists and people who used to work in this environment to work in the environment safely. But you know, these things have been known for a while, and MRI is not new right now. Obviously, there are advances, but MRI has been around for some time. So here you see way back in 2008, I believe this is, IEEE Engineering and Medicine and Biology, MRI Robotics, a special issue already. So again, I think it's like most fields. If you look back, most things actually have been thought of before, but they haven't always come to practice. And that's maybe because the time wasn't right, the technology wasn't developed enough, cost issues, turf battles, you know, all those things we see in the medical environment. But I do think the time is right for MRI robotics right now. And hopefully I can convince you later in the presentation as well. There is a standard for the MRI environment. So ASTM is American Society for Testing and Materials. But the key things here, and we always joke, this will be on the quiz later on too, because I was told I had to have a quiz. Well, okay, that's a joke. But the official terms, if you want to act like a real MRI guru, are MR safe, which is an item that proposes no known physical risk. So basically probably a system with no metal at all plastics. MRI conditional, an item that's been demonstrated to work in the MRI environment with certain conditions, and MRI unsafe, you know, which is most things not designed for the MRI environment. So again, there are standards, there are methods that you can follow when you build these devices. Just some real quick history of the MRI compatible robotics. So this is about 20 years ago here. This is a system actually at Brigham and Women's Hospital, for anybody who remembers the double donut there, where they used to operate in the bore of the magnet, which unfortunately was discontinued. It was a very low field strength magnet too, but I thought it was kind of cool that you could actually stand between the magnet and operate in this device here. There was Andreas Melzer out of Europe, worked with a system too as well, and formed a company called Inomotion. I can't read the German. My German's not good. The words are always very wrong. Forschungszentrum Karlsruhe, FZK, developed. This was pneumatic actuators. So the beauty of pneumatics, again, is that it has no artifacts in the MRI environment too. And they actually did a patient trial but maybe this was a little bit before its time and was not continued. There was the neuro arm from Calgary. You know, I always heard a lot about this at conferences 10, 15 years ago. I don't know that it's still viable, but this was supposedly what we call kind of a teleoperated system, where you could actually operate through the microscope, and you would have a quote master controller controlling a slave robot that actually be working on the brain of the individual inside the magnet here, and had something called haptics. Haptics is force feedback as well. But as far as I know, this system is not used nowadays. And this was from Calgary in Canada. Okay, we're gonna switch gears a little bit right here. So that was some of the MRI background. So let's go to shoulder arthrography. And I guess, Chris, I just keep going, right? And then at the end, we have the discussion, right?
Yeah, exactly. We'll do a panel at 8:30.
Okay, sounds good. All right, so save your questions there. If you want to liven it up, feel free to put in the chat. No, I disagree. This guy is completely wrong. You know, Zoom is a little bit hard to make interactive. And, okay, so shoulder arthrography. So that's me right here lying in the bore of the magnet. We always say, don't try this at home right here. And that's a little MR robot on my shoulder here. And the purpose of this robot would be to hold a needle guide here for shoulder arthrography. Now, shoulder arthrography is probably a little overkill for MRI. You know, we do that pretty well right now, but it was considered a fairly safe thing to start with because, again, there's no real critical structures here. So this is what we're going for our first clinical trial, which hopefully will start this fall. This is funded by an NIH R01, and this is my colleagues from Johns Hopkins University who built the system. And basically, we follow kind of a rapid prototyping motto. You know, we build the minimal viable product. We try to test as soon as possible. We do phantom studies here. You know, this is just mock-up. This is form and fit. We're not actually driving a needle into my shoulder right now as well. But then we try to progress and bring the engineers and clinicians together to develop the technology. The clinical need for this, the idea was that in current arthrography workflow, and arthrography is the injection of a needle into a joint and then contrast to evaluate joint condition. You first use fluoroscopy for needle placement and contrast injection. And again, that works pretty well, but in pediatrics, we are very concerned about dose. We do try to eliminate dose wherever possible. So if we could minimize the dose, that would be great. And then step 2 in the current workflow is you do get MR imaging for diagnosis. And again, generally this works pretty well, but sometimes there's a delay between the fluoroscopy injection and MRI scheduling. We generally get the next available slot. So what we would like to do is kind of one-stop shopping and do this all in the bore of the magnet. So this robot here that we put on the shoulder, which was originally built by my colleague Reza Montferretti and later picked up by Hopkins, is a 4 degree of freedom robot. So again, in the robotics world, we use the term degrees of freedom. For an object in space, we say 3 degrees of freedom for translation, X, Y, Z, 3 degrees of orientation. For example, roll, pitch, yaw, like in a ship. So if we want to move a needle, put it on the shoulder and orient it, we need 2 X, Y just for in a plane to place the needle tip, and rotation's about 2 axes. So that's why this is a 4 degree of freedom device here. It does not actively drive the needle. The physician would drive the needle. So we would develop a new workflow in MRI. And I think one of the big deals about introducing technology is you have to also consider the clinical workflow. You don't want to change. Physicians train for a long way for a good reason, and they're comfortable. You don't want to change the clinical workflow too much. So the workflow would be position the child in the MRI, secure the robot with straps, scan the region of interest. You would then get a series of scans, and you would plan a trajectory. So there'd be a trajectory. You would register the robot, which is the technical way of putting the robot in the same coordinate system as the MR scanner. So you can then command the robot to move the needle tip to the entry point, orient it the way you want. You could check again. You would then slide the patient out of the scanner, physically push the needle in, and then you would go back in, verify one more time, and then inject the contrast. Finally, remove the robot and obtain diagnostic images. You can see this robot does have a little metal. These are metal. You can use non-ferromagnetic material in an MRI. It will cause some artifact, but if you keep those motors away from the imaging area of interest, you're generally okay. So again, that is really kind of the art of MRI. So the system architecture here is a little bit complex, but you'll have the control room right here where the MRI tech sits, and this is where you have your planning station, robot control. Then you have the MRI room. The robot actually would mount on the patient here. The physician here is shown in the MRI room, but once you get comfortable, you can actually start in the control room, but it would always be under the control of the physician at all times. So we do say when we build these systems, we are not going to replace physicians. Obviously, we need their skill and talents. We are going to hopefully augment their capabilities, and maybe we can make some things more ergonomic for you as well. So this is some of the robot mounting with straps. It actually works pretty well to mount with straps so that if the patient moves, the robot moves with the patient. And there's not relative, you don't have respiratory motion issues in the shoulder. Again, we try to stay away from that right now with body mount robots. We won't get into image fiducials and registration. Did some phantom targeting experiments. So this is very typical, make a gel phantom with a bunch of targets. And we can show that these robots are pretty accurately, usually within a couple millimeters in phantoms, which we believe is suitable for the clinical environment. We did integrate an imaging coil. This was a big part of it. In MRI, you know, one of the big deals is you have to pick the right imaging coil so you get enough signal for good images. Typically, scanners can have coils built into the tables or also into the bore of the magnet, but a lot of times, as you know, that you'll get supplemental coils that you'll place on the patient. So here we actually had Cincinnati Children's, which has a very nice MRI shop under an NIH R21, build us a single loop coil that sat underneath the robot right here. And in the picture, the single loop coil is on the top with some flexible coils on the side. I'm scanning a ham phantom. Hams aren't bad actually for doing this type of work too. We don't generally eat them afterwards right here, particularly if we inject contrast, you know, it ruins the meat, just joking, of course. But anyway, hams aren't bad. Okay. All right, so let's go on to low back pain. You know, I think we saw from the presentation, I just caught the tail end of the clinical presentations, but obviously low back pain is a huge clinical issue. We all have it probably at some point in our lifetimes. So the idea for this PainBot robot here, and you can notice the theme, Arthrobot, PainBot, BoneBot, is that we want to actually do needle placement under MRI. And again, you may say this is overkill, but if you do look at the literature on pain injections, a lot of times they're non-diagnostic. And is that because you didn't get the needle in the right place, or it's because that place wasn't the source of the pain? If you do it under MRI, you get exquisite images of exactly where it is, and you can even watch contrast injection in real time. So this one has a 4 degree of freedom needle alignment, 2 degree of freedom needle box. Actuation box sits at the foot of the table. So what's a little different here is we will drive the needle down automatically, but rather than do it automatically, we'll let the physician drive it from the foot of the bed through this beaded chain transmission. So the physician can actually watch, and we can do real-time imaging in the bore of the magnet. So I'm going to skip ahead a little bit because Chris, I should finish by 8:30, right? So we should get to ICA.
Not a hard stop, but around then.
Around then. Okay. All right. So I'll probably cruise through some of these so we can get to ICH right here. But anyway, this is, again, very nice engineering from Hopkins. So 2 degree of freedom needle driver that can both drive and rotate the needle. Same idea with a 4 degree of freedom needle alignment module. And then underneath, fiducial markers and integrated imaging coil. So we're trying to build all these systems in a modular approach. Okay, so here's a picture of the integrated imaging coil. We had actually got permission to do some cadaver studies at Children's. Of course, that was pre-COVID. Right now, if I was going to get one in, I'd probably have to make sure it was COVID-free if they would even allow me. Okay, here's the cadaver torso study. You really can't see the cadaver. It is underneath the blue cover, but there's a company called Science Care, which literally provides fresh cadaver specimens. It can be a little expensive. I think this one may have even cost us $2,000 or so. But the beauty of it, it's a fantastic model. You know, when you do these procedures, doing phantoms and all that is great, but having real tissue, and because it's not formalin fixed, and these are fresh specimens as well, which obviously you have to keep refrigerated and used very quickly, but they're beautiful models for testing things. So we did this very nice cadaver study, brought the whole team together in the fall to do this. And we were able to show targeting here underneath MRI with the facet joint on the left and in the epidural space on the right. I only assume this is right, that my clinical colleagues tell me. There's obviously people on the phone who know much more about this than me, but you do see you get a fair amount of needle artifact. So that's one of the issues with MRI, that even with MRI compatible needles, you can get a little bit of artifact, making it a little difficult to see exactly where the needle is. So there are techniques to minimize that, but that's also an active area of research. Okay, last one before ICH, long bone biopsy. So this is kids coming to the hospital. They may be limping, have tenderness in the leg. and we want to get a biopsy sample as soon as possible to see whether it's osteomyelitis or infection or osteosarcoma here. So this idea here, instead of mounting the robot to the body, we would actually mount the robot to the table and affix it to the leg. But again, the same idea, there's no relative movement between the robot and the leg. The neat thing about this robot, which was built by Dan Stojanovic at another Hopkins lab, is that it uses pneumatics for control and optical encoding. So there are no electrical signals, and this presents no artifact whatsoever on MRI. So this is kind of the clinical need right here too. You can see how much better MRI is at looking at all the various tissue parameters versus CT. We did some phantom studies with this device, which really is just a very thick, heavy kind of needle guide right here. And then we made a long bone phantom here. We did some targeting studies. So here's some very nice visualization of the targeting studies. And we show that this robot also could be very accurate. So this is now in the second phase of the work where we're developing some new things and then hopefully go to clinical trial. Okay, ICH finally. So this is always a little tough for me because I'm talking to people here who know much more about this subject than me. But fortunately, my colleagues on the grant who can correct me. We did put an NIH proposal. It did score well. We hope to hear very shortly about funding. I'm optimistic, but I don't have the award yet. So the idea here, which basically from the proposal is evaluate whether ICH evacuation under IMR is feasible, which could provide a new treatment paradigm. We already talked about the advantages of MRI for CT, but in the brain, delineation of white matter tracks, greatly enhanced visualization, and of course, the lack of radiation, which means to me, you can scan as many times as you like during the procedure. ICH significance, again, probably talking to the choir here, preaching to the choir, as we say. ICH is very common. Number of ICH cases is projected to increase, and outcomes are generally not always that great right here. So I did list the references at the end of the talk. I can make a PDF available of the slides to Chris or anybody who's interested. So again, some pictures of ICH, what happens with the hematoma on the left here, in the middle right here, an open craniotomy here, and then on the right, neuroendoscopy device right here. So just kind of showing some of the treatment options. Limitations of current approaches. Very long slide. This is a slide that you make when you don't know how to break up what you put in the proposal and you don't know enough to say what's important. So I'll just summarize. Standard of care is watchful waiting. Decompressive craniotomy is alternative method. However, technique has not always been shown to improve outcomes here. Stereotactic clot evaluation is a good approach right here with a sheath through a burr hole. There are limitations of current instruments. When you have to tilt and torque them, you can cause more damage. The size of the device is large. And furthermore, intraoperative imaging is lacking right now. So we believe that real-time intraoperative cavity monitoring, such as offered by MRI, along with instrumentation, could improve the safety of the procedure. And that's what we put in our proposal. So here's the kind of artist conception right here of ICH under MRI with robotic assistance. Here is the patient on the table. Here you have a robotic device, and we'll talk about these concentric tube robots, which is a very thin cannula that we can deploy that can also be curved right here. And then we would have a control and monitoring system. So some sort of workstation, some sort of joystick interface where the physician would be manipulating the device remotely, but would be still in the same room or same area as the patient. The MRI robot, this is from my colleague Wei Chen at University of Arkansas, who developed all the technology and is on the talk here. The MRI compatible ICH robot. So here you see these motors, and what they work is to drive this little needle-like device that we'll talk a little more about is a concentric tube device. And then here's some results on the right in a phantom study. So here's the idea of these concentric tube robots. Think of it as a bunch of straws you can pass through that they can bend. They are pre-curved, so once they go through here, and then the trick is, of course, how to control these devices right here to get along the path you want. But you can see the size of these can be very small. This is a little picture of the concentric tube ICH remover. The outer tube comes in and it's stiff. You have an inner tube which is pre-curved and super elastic, so when it's deployed, it can curve, and then showing how it can be used to evacuate the blood clot. Here's some pictures of some studies that Wei Chen gave me right here. So again, these are in MRI, and you can see air hose, pneumatics, plastic materials. So the trick is building all of these things out of MRI compatible materials. And then your controllers and other things here go further back in your MR safer zone right here. This is a picture that Wei shared with me. You can see from the bottom here, you have a device and a phantom moving in towards a clot. So the main idea of this video is showing that you can move and advance in real time. You can see here, we still have fairly large instrumentation, but you can do real-time monitoring. And then eventually, once you get there, you can watch, as you do evacuation. Okay, user interface. So again, this is for the tech people out there. We are basing this on 3D Slicer, which is open source software for image-guided system for Brigham and Women's. The beauty of that is they have a nice module for diffusion tensor imaging, DTI, that we would integrate. And then hopefully in the path planning and everything we develop, this could help you avoid the critical regions. A validation study, what we proposed were 2, and a phantom study, a brain gelatin phantom inside a plastic anatomical skull, and a sheep animal trial. We started with swine in the first submission, but they didn't like that. They thought sheep was better. So we know in NIH proposals, it's better to go with the flow if you can. So we switched to sheep, and hopefully that did the trick right here. And here's some previous validation experiments in swine. Some of this work was also done by our colleagues at Vanderbilt University. All right, next steps in the team. So again, we're on pins and needles, as we said, waiting to hear on NIH R01 submission. For those of us who play this game, I've been in touch with the NIH program officer, so I'm quite optimistic, but until we get something called the NOGA, Notice of Grant Award, or NOAA, Notice of Award now, we can't, we just have to wait and see. But we have a good team, myself, Dr. Sharma, Dr. Oligabu from our hospital, a neurosurgeon, Wei Chen, who's really going to be our technology lead at Arkansas, and Dr. Izuru Gadij and Sakit Sengupa are the PhDs who are going to help. And then finally, Dimitri from George Washington and Chris from Mount Sinai. So this is really, I think, helped our proposal, was assembling the team together. Okay, these are some references for the record. Again, these will be in the PDF copy right here too as well. And just to conclude, I think MRI robotics is still an emerging field. It's still early in this development. We need new systems and methods. I think the benefits, of course, could be substantial, being able to work into a magnet. Of course, the cost are issues as well, too, that will have to be considered. Some commercial systems are starting to appear. So there are some companies having products in this space. We need to continue development, and with the eye always to moving to clinical trials. So not just to develop technology for technology's sake. We need to have a strong partnerships with engineers and clinicians, and obviously research funding is critical. And we've been fortunate to do pretty well on that front with NIH. These are my acknowledgements. So colleagues at our institute here, colleagues at Hopkins, both the Robotics Laboratory and the other robotics laboratory on the Homewood campus, and then some of the NIH funding. So with that, there's my contact info. And thank you for your attention. So again, you're welcome to visit us when we're allowed to have visitors again. Hopefully we'll be soon. And hopefully things are going in New York. And I'm really happy, Chris and everybody, that we could do this by Zoom today. And hopefully we'll be able to meet in person at some point. So let me stop there, and I guess we can go to the panel discussion.
Really fantastic talk and inspiring work. Thank you so much. It's odd on Zoom, you can't hear clapping, but if we could, there would definitely be clapping. So thank you. We have assembled an expert panel here, and of your co-investigators, Dr. Karun Sharma, Dr. Wei Chen, Dr. Dimitri Sagunis, and then also on here are Dr. Anthony Costa, who is the director of Sinai Biodesign, which is our attempt to imitate what you have with engineers working next to clinicians. And then also Dr. Jay Mako, who is an ICH expert and stroke expert, has done some work with robotics and ischemic stroke. So I'll start, and other people can ask questions by posting in the chat or raising your hand as attendees. And I just wanted to ask you, what changes have occurred since 2008 and since those other robots that you showed that things didn't work out? What have been the advancements that would allow this to work out now?
Yeah, I think the main change, of course, has been the advance of rapid prototyping, in 3D printing, that we all know, of course, like any new area, it's overhyped, just like machine learning and everything else is overhyped. But these are, tools that are available. So now that we have in our lab the ability to design on the computer and 3D print something that's MR compatible, That's been huge. And then I would say the second part is I do think MRI usage, while not exponentially, but steadily has increased. And, particularly here at a children's hospital, we have more MRI capacity than CT, and we do more MRIs than CT. So I think those are the two main factors is the really, I would say, still technology advances.
I see Dimitri Segunis is wearing a mask and lead, so I want to give him a chance to speak before he starts a procedure. Dimitri, what do you see as a barrier or as the main barriers to adopting this in ICH treatment?
Thanks, Chris, for the invitation to be a panelist, and great presentation, Kevin. So I think that the MRI technology is something that is the future for doing image-based techniques. But again, I mean, the fact that it's not ubiquitous, it's not at most health centers in the United States, and there's not a rapid protocol for being able to get patients to have rapid scans in a process like hemorrhagic stroke, means that it's going to be a little bit more slow to be adopted. That being said, I think eventually it will get there, and I think that the centers that do have MRI capabilities and intraoperative MRI capabilities are going to really move towards this type of technology to be able to evacuate ICH. The second barrier, I think, is physician related. So physicians are very traditional in most cases, and don't accept technology or a new procedure unless it's really been borne out. And for this, I commend Chris and Jay Mako's work at Sinai to be able to show that IPH evacuation is necessary and helpful in improving patient outcomes. So once that becomes standard of care, I think there's going to be a universal push to be able to adopt minimally invasive ICH evacuation techniques, and doing this in a way that doesn't require a learning curve and rigorous training would be helpful to be able to get it accepted on a widespread basis.
Thank you, Dimitri. Dr. Betterson, do you have a question?
I do. Thank you. Thank you both and all of you for presenting. It's fantastic work. I'm glad that we're helping to advance your cause. I believe firmly in it. But at the risk of sounding too old, I also want to get back to a couple of points that I think are important. I mean, why are robots helpful in surgery in general? They're helpful for repetitive tasks. They're helpful to increase precision. They're helpful because they're immune to hazards. They're great for simple interactions and for things that require intensive labor. So those to me are the main reasons why robots would be helpful on a theoretical basis. So we have to look at why a robot would ever be helpful in doing something such as removing an ICH. Because it's a simple procedure, okay, it's not intense, there's no hazards. Repetition is not important because there's a unique ICH every time. So really, you'd have to focus on precision, which to me would mean something like, efficacy of clot removal, that sort of thing. And then you have to, get into the cost and so on. So this is the first point, and I will stop talking and allow you to speak. The other is that, as Dimitri said, this is good for image-based procedures. And you referenced the Calgary project, which was part of NASA. There was millions of dollars in that. And Canada, actually, the Canadian Research Institute, which was based in Montreal, started with a haptic-based simulator for neurosurgery. So they have a great history in this, which has included haptics. In my view, the hardest part of surgery is not the visual feedback. It's the haptics. And it's haptics that improve the surgeon's precision. So I think that these two things are related as to why a robot would be related or why a robot would be helpful, when it would be helpful, under what circumstances, and how we can then use haptics to our advantage to improve precision going forward. So I don't want to hijack the conversation or derail it, but these are just points that I wanted to make as part of this excellent presentation. So thank you.
Yeah. So let me just respond quickly. Yeah, excellent points. It is true. I mean, even with Da Vinci robot, there are some questions still. Is Da Vinci really better? Or was it all just marketing? Or, as some people will say, did it make people who weren't great laparoscopic surgeons better? All those questions, still exist. So, I think the role of robotics, and my PhD was in robotics, and I actually worked on something called Flight Telerobotic Servicer before it became the Canadarm and got into medicine. But anyway, I think, it's still searching for its place in medicine. But, I do believe that someone needs to push the state of the art, and if we don't have that, then, we won't have any new things right here. So if robots could let you operate in the bore of the magnet, through a teleoperation and give you better precision, as well as real-time visualization in an ergonomic way, I think that would be great. We don't have haptics. Haptics is still an elusive issue. Again, Da Vinci doesn't have haptics. Some people say they learn to compensate, or when they first use Da Vinci, they break a lot of sutures because they're not used to how hard they pull. But nobody's been able to give good haptics and reproduce that sense you have at your fingertips with an easy-to-use device. So I think haptics is still a research area. So I think all your points are valid. Just from our position as researchers, we do still aim to advance the field with the optimistic view, perhaps, that hopefully someday this will lead to some technology that will find its place in medicine.
Cool. Hi, I'm Anthony. Thank you very much for the presentation. I learned a lot. You can tell I'm the tech guy because there are 3D printers behind me and a few others over here. I was wondering a bit on a couple of things. I have a bunch of technical questions too, but we'll leave those for another time. Someone mentioned sort of, the limitation of, access to MRI and this being a fundamental limit on the deployment of these technologies over the last 20 years. I wonder if you've seen or have worked in any space where you might think about how these robots are applicable in a world with imperfect information, not simply, full 3D nice reconstructions where the target is easy to identify. But are there technologies either in sensing or any type of feedback that would enable the application of robotics in environments without perfect information?
Yeah. Well, I mean, obviously the people now working in machine learning, in all those fields, in quote, artificial intelligence, if you want to call it that, would claim that they can now do that, by assembling huge data sets, and running algorithms, and neural networks and things like that. But, I'm skeptical there. To me, the clinician is always responsible for the patient care. And even for the systems we develop, we always think, would we want to use it on us or on our kids? And so a deterministic system I would be okay with in some sense, right now. But I think the whole field of, the AI is still evolving. It probably would be great in the future if, while you're doing a hematoma evacuation, if you had access to a large literature of that and could show similar clots and what had happened in the outcomes, when the technology is there. But I think that's still pretty far off in the future. And I certainly wouldn't trust it yet.
Yeah.
We've got Ted Panov also on the line. He is a functional neurosurgeon here at Mount Sinai. He's done some work on MRI guided DBS. So I wanted to invite him to comment as well.
Thank you, Chris. And guys, thank you. It's an excellent talk. Just wanted to show you how close we are to this potential collaboration here at Mount Sinai. We've been doing robotic guided all intraoperative MRI cases now approximately for 3 years here. The majority of them are laser ablations for epilepsy. We've done a few placement of DBS electrodes as well as biopsies. And a lot of the attendings here are very interested and very involved. The combination right now is with a device that is MRI compatible, has 4 degrees of movement as you're discussing, and it is attached to a robot, fairly simplistic one, of course, nothing like what you guys have, but the NeuroBlade device that really right now just advances the probe. And everything that you've said so far just echoes so deeply in us to be able to do this. Even something like holding the endoscope for Chris already would make the lives of the residents so much better, potentially for this case. The ability to be outside of the 3T scanner as the procedure is performed would assure much better sterility. You would not have to open the door. You would not have to stop the scan. So to us here, robotics is the next step. And I think that we're underutilizing that significantly. I want to encourage any and all of you guys who can, please come and visit the center here. We could get you through as to what we're able to do right now. And I think so many light bulbs will go off for everyone on the team to be able to push this further.
Yeah, no, that's great. We look forward to hopefully getting the funding and having a kickoff meeting in New York. Would be fantastic.
There's been some robotics developed for ischemic stroke treatment, and Jay Mako is online here, and he's been involved in evaluating that and developing that. I wonder if you could comment on parallels between robotics for ischemic stroke and robotics for hemorrhagic stroke.
I think there's some great parallels. It ties a little bit to what Dr. Betterson was saying before about the challenges of haptics. When we move towards endoscopic, purely endoscopic procedures, not endoscopic assisted procedures, and endovascular procedures, while there is a haptic component to it, it's very likely that that same information can be transmitted in a different way with a tachometer or some other kind of feedback, much the way people master extremely complex and sophisticated moves in video games. And once you deal with that aspect, everything we do in a pure endoscopic case or and aside from the approach and in an endovascular case, aside from the access, is all brought to us through machinery, through imaging or other things. And so I think they both represent outstanding targets for robotic innovation. I've been able to be involved with this technology company called Corindus that's had tremendous success developing models along those lines for endovascular approaches. And I'm incredibly enthused about the idea for intracranial. I think the biggest limitation from what I see right now, and we have to start moving, we have to start somewhere. But I think that from the prototypes and the concepts that I saw discussed is the degrees of freedom once intracranial and the precision of movement. In the vasculature, having that sort of angled tip that you can then orient gives you tremendous amount of flexibility, because what you essentially do is bounce off the walls. But when you're intracranial dealing with a hematoma, you can't do that. And so mastering that component of the technology, I think, is going to be crucial.
Great comments.
It seems to me like you really take advantage of the ability of repeat imaging in the MRI. And I wanted to ask Dr. Sharma and Chen, how live is the MRI and how live can it become? Can we get real-time imaging like we do in IR, Dr. Sharma? Do you think that's going to be a limitation to these procedures?
Well, Chris, I think that, here, let me make sure, that is one of the exciting parts of this project and proposal. I believe we can get real-time imaging. The challenge to real-time imaging for those of us that work on the body side is the respiratory motion and pulsation and all the artifacts that come along with that. And it makes a lot of sense to start in the brain or the spine, where there are fixed structures that are not prone to respiratory or other motion. So I do think that the real-time imaging is within reach. To me, the current limitation is sort of the needle artifact that we have from things that are, when we do, for example, bone biopsies. With the currently available materials and designs, we encounter a significant needle-associated artifact, despite all of the things we do to sort of reduce it from a sequence perspective. I think that with the technology of being able to have these concentric tubes and different materials, I think we will get around that as well. But I do believe that the real-time imaging, like was shown in the Phantom, which is stationary and not moving, is something that we can achieve in the brain and around the cord.
Very cool. Dr. Chen, from your perspective, what are some of the limitations to developing this robot?
Okay, so basically, so what we can do with real-time imaging now, so we can get around 1 to 2 hertz update rate for the real-time imaging. So basically, from the video Kevin just showed, So we did a test for the one-dimensional imaging, so one-directional imaging. So the updated rate is 1 Hz. But for the image artifact, so actually, so I'm collaborating with another MRI scientist. So what we are trying to do is to carry some current into the needle, into the metallic needle, so that we can address the image artifact. So we have already done some simulations, and it shows it can reduce the image artifact. Instead from the tracking sequence and also MR sequence part, we are trying to add some component to automatically make the magnetic field homogeneous. And so another area is the haptic feedback. So that's the most challenging part. So in the proposal, so we mentioned about some haptics like the virtual fixture, but still there will be a lot of work, and especially once we have the haptics is based on the image-based haptics, but we haven't validated whether it's accurate or sufficient enough to provide the guidance once the surgeon remote control this robot hardware. But it will be a very interesting topic we want to explore in the future.
So you said that you are manipulating the electrical current in the device to mask it in the MRI scanner.
Yeah, so basically, so we're trying to use this metallic needle, and we make some device and make some component, and this component will carry some current. So this current has some specific design, and so this current will generate a small magnetic field, and this magnetic field can compensate to the inhomogeneous of this metallic needle. So ideally, so we will address image artifact. So this is another Articulum proposal funded by Saka Zenkuda. He is the MR scientist in this proposal. So we're working on this project right now.
Great concept. Any final questions? And so with that, yes, Dr. Panoff.
Sorry, just a quick comment here regarding the artifact, guys. We've been using ceramics to be able to get around the artifact. Of course, that's a much more fragile and brittle substance, and we do have breaks in the stylets often. But I want to just encourage you, continue that work for sure to get the artifact to be down. Although the procedures that Chris thinks of doing, the size of the hematomas and the ability to evaluate them, I think that the project most certainly should move forward. We will be able to see the artifact of the needle. It will be large. You're never going to miss it on the scan, and you'll be able to see that it's next to the hematoma or in the hematoma. So most certainly it's not an absolute contraindication.
Great.
Well, Dr. Cleary and team, thank you so much for speaking with us today. This has been fascinating, and I look forward to working with you.
Thanks to everybody. Yep. Bye-bye then. Yep.
Thank you.